Magandang umaga, RMI. Good morning. I hope everybody is feeling well. For today, we will be discussing a topic different from the topic that has been discussed in previous webinars. We will be dealing with a very important pulmonary disease that is very relevant today as it was in the previous years. Let me start off with this first slide. In medical school, we were taught that if we are to understand what is abnormal, we have to have an understanding of the abnormal and the normal functions of a system. So I'll start first with normal respiratory anatomy and physiology. This is our lungs. We have the right and the left lung. And the main function of our respiratory system is breathing. When we say breathing, this means entry and exit of gases coming from the atmosphere. We inhale oxygen, goes down through our windpipe, from the nose to the windpipe to the right and left lung. Anatomically, the lung is composed of airways or air tubes that divides into smaller portions. We call this the trachea, the bronchus, and the bronchioles. The terminal portion of the respiratory system are these grape-like structures we call the alveoli. Now, the alveoli, which amounts to around 300 million air sacs in our lung, is the one responsible for gas exchange. And as this slide would show to you, the air, which contains oxygen, enters the alveoli, goes into the pulmonary capillary, which is the blood vessel. Oxygen enters and carbon dioxide goes out. Now, this has to be maintained normally if we are to have normal respiration or gas exchange. We also have different protective mechanisms, one of which is what we call the mucociliary escalator system or the mucociliary apparatus. The purpose of this apparatus is to remove the secretions from the periphery or the smaller tubes of our lungs to the bigger tubes so that we will be able to expectorate them. Now, this is how the mucociliary apparatus is functioning. You see this swiping move in this area, which is actually the mechanism by which the secretions or excessive phlegm would be taken out from our lungs. Now, the mucociliary apparatus beats several times in a second so that it can be effective in doing its function. If, for example, we expose our lungs to detrimental factors such as this, then we can have problems. We might end up, instead of having a normal lung, to a destroyed lung, such as this one that I'm showing to you. It is easy to understand now that if you have an abnormal destroyed lung, the function of respiration will be disturbed, and eventually this can lead to so many symptoms. And you may end up as a patient who is wheelchair or bedborne. You can be weak, you can be short of breath, and you might even need continuous oxygen treatment. So for today, we are to discuss chronic obstructive pulmonary disease. There is no Tagalog translation, so we coined our own translation. Chronic means prolonged. Obstruction means there is impairment of airflow. Pulmonary is the lungs, and disease is an illness. So sa Tagalog, ang translation namin dyan ay pangmatagalang pagbabara ng daluyan ng hangin sa baga. And that translation actually encompasses the different features of this disease. Now let's go back to history. This is an old slide, but it tells you that diseases like cardiovascular from the 1970s to the early 2000s is seemingly going down. Cancer is more or less the same. Stroke is going down. But you can see in this slide below that chronic obstructive pulmonary disease from the 70s, 80s, 90s to 2000 is going up. So in the year 1990, chronic obstructive pulmonary disease was estimated to be the number 6 disease. And for the year 2020, it is expected to go up and become the 3rd leading cause of disease globally. Well, this is an old slide just showing to us that chronic obstructive lung disease and allied conditions was number 7 in terms of the top 10 causes of mortality in our country. Well, this is also an old slide telling us that in the Philippines, years ago, that the prevalence rate of COPD is around 6.3%. So this is estimated to be more than 1.6 million cases. A more recent study showed that chronic obstructive lung disease is roughly around anywhere from 12 to 14%, and more men were affected than women. We will elaborate more on this later. Now, how did the normal lung become an abnormal lung? The mechanism is really quite complicated. Just to simplify things, exposure to, for example, to particulate matters or cigarette smoke will eventually lead to a cascade of inflammatory agents that will eventually produce abnormalities in our airways. For example, when you have a normal inspiration and expiration, your alveoli would be also moving to a certain extent. But if you have chronic obstructive lung disease, specifically emphysema, there will be difficulty in expiration of air, leading to the enlargement of your dysfunctional alveoli. In terms of air tubes, instead of a normal anatomy in your air tubes or a normal mucociliary apparatus, the mucous glands becomes hypertrophied. Ibig sabihin nun, lalaki at dadami, and they will manufacture more phlegm. So essentially, a patient with COPD will be short of breath, there's difficulty of breathing most of the time, and they will be having frequent episodes of cough because of this mechanism. Now, in the management of diseases, at this time we follow guidelines. And for COPD, the guideline that we use is called GOLD. That is Global Initiative for Chronic Obstructive Lung Disease. And this is the organization that actually gives us the standardized guidelines for treatment so that patients with this problem can receive optimum therapy. First, let's go to the definition. This is an old definition. This was given by Gold in 2007. It states that chronic obstructive pulmonary disease is a preventable and treatable disease with significant extrapulmonary effects. So this means that COPD, although it's a pulmonary disease, it's not really an exclusive pulmonary disease because there can be extrapulmonary or systemic complications. It is also characterized by airflow limitation that is not fully reversible, and the disease is progressive. It means you might start with a mild disease, but eventually the disease will progress. Well, through the years, the definition has been modified, and this is the latest definition of COPD. It is still considered a preventable and treatable disease with persistent symptoms and airflow limitation because of abnormalities in our lungs. The most common symptoms will include dyspnea or difficulty in breathing, cough, and or sputum production. Now, the main risk for COPD is tobacco smoking, but there are other factors that may cause the disease. Right now, we have already seen some data. Predisposing factors may include genetic abnormalities or abnormal lung development and even accelerated aging of the lung. COPD may be characterized by exacerbations. When we say exacerbation, this means worsening of the already existing respiratory symptoms. Patients with COPD are expected to have chronic cough and recurrent shortness of breath. But when they go into exacerbation, these symptoms will become worse that might necessitate emergency room visits or unscheduled visits to their doctor. One of the most important features of COPD is it is accompanied by other chronic diseases, which may increase its morbidity and mortality. COPD is a very important disease. It is actually a worldwide problem, as I will show to you in the succeeding slides. In terms of prevalence, COPD is higher in smokers and ex-smokers when compared to those who never smoke. It is higher in prevalence rate in patients who are 40 years and above, and it is higher in men than in women. As early as 2010, it is estimated that there are around 384 million cases of COPD, with an estimated global prevalence of about 11%. Now, look at this statement: 3 million deaths annually. Right now, we are all scared with COVID because the prevalence is rising, and globally, there are more than 9 million cases with around about 500,000 deaths. But you can see here that the mortality in COPD is much, much higher. So that's 3 million deaths annually, every year. Now, with the increasing prevalence of smoking and other exposures in developing countries, COPD, the prevalence of COPD is expected to rise even more in the next 30 years. And by 2030, the predicted annual death for chronic obstructive lung disease can reach to as much as 4.5 million. So this is one thing I think that we have to bear in mind. It is just but correct to be afraid of COVID-19. But looking at this data, I think we have to fear more chronic obstructive pulmonary disease. Now, exacerbations can bring about the greatest cost of taking care of COPD. For those having stable disease, the treatment is expensive. You have a lot of medications that are needed to maintain them. But when they go into exacerbation, the expenses and the suffering becomes much, much higher. So you can see here from the data from the European Union that they are spending around about 38 billion euros for this disease, and in the US, it will be around 32 billion US dollars with indirect cost of around 20.4 billion. Now, I do not have the numbers in the Philippines, but from the patients, from the cost of treatment that we see in our patients, the cost for treatment, especially those with recurrent exacerbation, can be staggering. So these are the factors that can influence the progression of the disease. In the definition, we say that the disease is progressive. Once you have the disease, especially for those having moderate to severe disease, there is no turning back. The disease will progress. And there are certain factors that can influence the progression, like existence of genetic factors, lung growth development, exposure to particles, airway hyperactivity, and infections. In this slide, I am just trying to explain to you the inflammatory and cellular infiltration nature of the disease. COPD is not just a disease of obstruction. It is a disease of inflammation. So, ibig sabihin yan, nagkakaroon ng pamamaga sa loob ng katawan ng isang pasyenteng predisposed sa COPD. Now, I'm showing here a slide that demonstrate to us the different types of cells that can eventually give out inflammatory agents that can lead to the destruction of our lung. And eventually, they can lead to emphysema, which means destruction of the alveoli, and mucus hypersecretions, which we call chronic bronchitis. So again, a patient with COPD will be somebody who will be having chronic cough and progressive shortness of breath. Now, how do we assess and diagnose this illness? First, we start with symptoms. So they have shortness of breath, common sputum production, and then we look into their risk factors, their occupation, their history of smoking, their exposure to outdoor or indoor pollution. If you have these patients and the patient is 40 years and above, it is a must that you have to do spirometry or pulmonary function testing, which is something like this. The patient is asked to inhale and exhale through a machine, and then the machine picks up certain numbers, and we will be able to objectively say the presence or absence of obstruction in the airways and be able to determine the degree of obstruction. Now, when we do pulmonary function test, there are many numbers that will come out from the study. And through these numbers, you don't have really to memorize this. This is just for the sake of demonstration that there are numbers that will be able to qualify the patient if he is suffering from mild, moderate, severe, or very severe disease. The smaller the number, the more severe the disease. And the more severe the disease, the more symptoms and the more medications will have to be given to these patients. This is like the ECG or the 2D echo of the cardiologist. In pulmonary function testing, we are able to estimate the amount of obstruction in the airways of patients that we suspect to be suffering from this disease. This just tells us, okay, the FEV1 is a parameter that we use in estimating the obstruction in our airways from a pulmonary function testing. Now, normally all of us, as we grow old, our lung function, as represented by this line, normally if we don't have any disease, our lung function would go down as we grow older. However, if we have predisposition to COPD, and you have other risk factors like smoking or exposure to small particulates, then the lung function will go down much faster. So clinically, this means that a progressive fast decrease in FEV1 or lung function would denote more symptoms and more severe disease. We can discuss this further if you have any questions during the Q&A portion of our webinar. Now, COPD is actually a multi-component disease. There are many things going on in a patient with this type of illness. So you can have dysfunction of your mucociliary apparatus. There can be destruction in the anatomy of the lung. There can be inflammation of the airways. There can be airflow limitation. And at the same time, there can be a systemic component. So right now, we don't really look at COPD as an exclusive lung disease because there are systemic complications that can happen. So I pose this question: can this obstructive airway problem be more dreadful as systemic disease? Unfortunately, the answer is yes, because COPD can have complications in the cardiovascular, osteoskeletal, hematological, even psychosocial functions, and even in the nutritional status of patients. So these are the systemic effects of COPD, and it will encompass several organ systems in our body. And depending on the systemic side effect, the symptoms of patients with this lung disease may even get worse. Now let's look at the nutritional abnormalities. It is estimated that a big part of patients of the COPD population would have malnutrition. That's anywhere from 26 to 47%. And if you have a body weight of less than 90% of the ideal body weight, this becomes a negative prognostic factor, which means that complications of the disease becomes higher. And in terms of survival of these patients, a lower BMI is actually inversely proportional to survival. Now let's go to the musculoskeletal dysfunction in COPD. The conditioning, if a patient just sits down or always in bed, the tendency of the skeletal muscles is to atrophy. So you can see some patients, when they are always short of breath, they are just sitting down in their bed or in the wheelchair, they have atrophied muscles. Lumiliit yung muscles nila sa legs at saka sa arm. And nutritional depletion, if the patient is not taking adequate nutrition, this can further aggravate this muscle dysfunction. Likewise, systemic inflammation, the use of corticosteroids, decrease in anabolic hormones, oxidative stress, and decrease in oxygen levels may all contribute to the muscle dysfunction of this patient. Kapag nagkakaroon ng peripheral skeletal muscle dysfunction, mas papayat ang pasyente, mas mahihirapan siyang kumilos, mas lalo siyang mahihirapang huminga. Now, physical inactivity actually would make the matters worse, so that exercise training to a certain extent can improve the muscle function of these patients. The disease also would have some effect in our bones. For example, the prevalence of vertebral fracture is around 29% among COPD patients. Osteoporosis in severely ill patients would be present in 68%. And the systemic use of corticosteroids like prednisone, prednisolone, given IV or oral, are some of the most common causes of drug-related osteoporosis. If you have osteoporosis, yung buto natin mas nagiging malutong and therefore mas magiging prone sa fracture. Now, how about heart disease? Now, because of the systemic inflammation occurring in COPD, that systemic inflammation can also happen in the heart. So there can be some ischemia, some obstruction in your coronary arteries and systemic arteries, and eventually you can have coronary artery disease. The prevalence of, of cardiovascular disease is around 33.6% in patients with COPD, which is much higher than those patients who are not suffering from chronic obstructive lung disease. And the anticipated cardiac problems will include failure of the heart, hypertension within the lungs, coronary artery disease, and abnormal heartbeats. The prevalence of psychiatric disorders among patients with COPD may range from anywhere from 30 to 58%. So that if I see a patient with COPD, almost half or little over half of them will have psychological issues. And among these issues would be depression and anxiety. So madalas nakikita nyo sila yung madalas na ninenervyos at very anxious dahil sa kanilang karamdaman. Now, lowering of the oxygen actually can worsen the symptoms. If there is mild hypoxemia, there can be some impairment in their reasoning or in their auditory and visual attention. If the hypoxemia worsens, even their movements and overall strength will be affected. So if a patient with the disease will have dyspnea and fatigue, they will be likewise anxious and they will also have poor motivation. And in certain cases, we have to refer these patients to the psychiatrist so that they can help them address these issues. This succeeding slide would tell us why these patients very anxious when they have the experience of difficult breathing. There is a delay in the emptying of the air in their lungs so that their lungs will become hyperinflated. When you say hyperinflated, this means that their lungs will become like balloon-like structures, and eventually this would increase the work of breathing. That would increase the workload of the respiratory muscles, and therefore it intensifies the patient's respiratory discomfort. So kung ikaw yung pasyente na madalas nang hinihingal at ninervous ka dahil sa ventilatory limitation, na-amplify lalo yung perception nila ng hirap ng paghinga. So in most cases, this can be a reason why these patients would go to the hospital or emergency room if they perceive that there is a progress in their shortness of breath. Now, how about the treatment? Okay, the first thing I'd like to say is there is no cure for COPD. So ibig sabihin lang yan, wala tayong gamot na currently available na makakatanggal ng chronic obstructive lung disease. Once you have it forever. No? Before, when I do these lecturings, I would say that COPD is like a diamond. When you have it forever. Tandaan niyo yun. Okay. Now let's go to the available treatment that we have. Although I said that there is no cure, there is, however, treatment that can help these patients become more comfortable and with less episodes of cough and difficulty in breathing. And it can range anywhere from intravenous, oral tablets or capsules, and inhalers. The GOLD guideline actually gives us the therapeutic options so we can have the appropriate medicines. And earlier I said that there are no existing medicines that can cure the COPD, and likewise, there are no diseases as of yet that would modify the long-term decline on lung function. And vaccines like influenza and pneumococcal vaccination should be offered depending on the local guidelines. So the primary mode of treatment will be prevention. And this can be done only by elimination or reduction of exposures to whatever can be triggering or aggravating the disease. There should be a reduction or avoidance of indoor pollution, and the patient is advised to avoid exercises outside of the house or the room during episodes of pollution levels. Now, these are the different groups of medicines that are currently being used in the treatment of patients suffering from this disease. We are using inhalers, we are using beta-2 agonists, anticholinergics, combinations, methylxanthines. These are the technical names of the drugs that can afford bronchodilation. When you say bronchodilation, this means opening up of the closed or closing air tubes. Aside from bronchodilators, we also have steroids that will reduce the inflammation of the air tubes. And steroids can be given either as inhaled or systemic corticosteroids that can be given as tablets or as injectables. Now, bronchodilator medications are central to the management of symptomatic COPD. They may be given as needed for the short-acting bronchodilators, but for some patients, they would require a maintenance of this treatment so that their shortness of breath would be reduced. And the choice of treatment really depends on the availability of medication and the patient's individual response to treatment. We now have what we call the long-acting inhaled bronchodilators, which are given once or twice a day. We also have combinations of different medicines that has shown efficacy in decreasing or improving their symptoms and decreasing the side effects of some of the medications that are being given to these patients. Inhaled corticosteroids are being given as a controller medicine, so they reduce the inflammation. Although more recently, there has been some advisories that there are selected groups only of patients with COPD that can be given inhaled corticosteroids. This is due to the fact that there can be complications. Giving inhaled corticosteroids may increase the risk of having pneumonia. Although we are not saying that this should not be given to patients, but this is a precaution and this would mean that there is a necessity that this medication should be given under strict medical supervision so that they can avoid the possible complications of treatment. Now, in terms of combination, yes, there are studies that would show that combination of inhaled corticosteroids, long-acting beta-2 agonists, and other medicines really can help in opening up the airways. Now, vaccines are of paramount importance for these patients. Influenza vaccines can be given uh, annually, pneumococcal vaccines, depending on the type of pneumococcal vaccine. It can be given every 5 years, or there is a vaccine available that is given only once. Now, antibiotics. Now, I always say that we always have to be very careful in using antibiotics in any person, not only in patients with COPD. If there is a suspicion that the patient is suffering from bacterial infection, yes, you can give antibiotics and you have to give the full dose. If the patient is suffering from a viral disease, you're not supposed to give any antibiotics because viruses would not respond to antibiotic treatment. Earlier, I said that the classification of the disease based on pulmonary function test will be mild, moderate, severe, and very severe. But more recently, because of the lack of sensitivity of this diagnostic procedure in terms of prognostication, the disease, and as guide to treatment, the classification of COPD has become a little bit more complicated. Instead of relying only on pulmonary function testing, we rely on the symptoms, additional symptoms of the patient, depending on their answers to a questionnaire. And we also use the risk of them being confined in the hospital because of exacerbation. So right now, we don't really just say mild, moderate, severe, or very severe. We label them as A, B, C, D. A are those suffering from milder disease. D, with more serious disease. C and D are the ones with the most serious disease. So if you are labeled as A, that means you have a milder form of the disease. If you are labeled as patient D, you have a very severe disease. And this is just the basis of the classification. So that's A, B, C, D. The higher the letter, the more symptoms, the higher the risk of complications. And this is important for the physician because this is the one that will determine the type of medicine that will be given. So ABCD, for A, you may give your short-acting bronchodilator only on a when-needed basis, but as your disease progresses from B, C to D, more medicines will be given. Okay, this is an illustration of the medicines that will be given. When you say short-acting bronchodilator, these are your salbutamol, the inhaled corticosteroids combination with long-acting bronchodilator are those with salmeterol and fluticasone, and the LAM or the long-acting muscarinic long-acting muscarinic cholinergic agents will be tiotropium. Okay, so the more severe the disease, the more medicines the patient will receive, and this is the latest graph for as guide for physicians to determine what medicine is appropriate to be given for this patient. The real goal really for milder disease is the less medicine, the better. But as the disease progresses and you already have the permanent damage in the lungs, your patient to be having or to lessen the symptom would have to receive more medicines to open up their airways. So the goals of treatment will be to to reduce the symptoms, which would include exercise intolerance, and we also have to improve their health status. And we want to reduce the risk. You want to prevent fast progression with disease. You want to reduce the exacerbation, and you want to reduce the mortality. Okay. Patients with airflow obstruction, through this mechanism, eventually will have shortness of breath. And if your patient would have shortness of breath, that patient would reduce his activity, would probably be always on the chair or in the bed, which will lead to further deconditioning. If this happens, the quality of life of your patient will be very poor. And unfortunately, this becomes a vicious cycle as the disease progresses. So what do we do? The mainstay I said earlier would be bronchodilator. If you give bronchodilator, this opens up the airway. This would reduce the shortness of breath of patients. This will enable them to do more activity and will be able to afford them a better quality of life. However, we mentioned earlier that the ventilatory limitation is just one aspect of the disease. Other problems would include cardiac dysfunction, musculoskeletal dysfunction, respiratory muscle dysfunction, which eventually led to the start of a program we call pulmonary rehabilitation. Now, pulmonary rehabilitation is considered to be a standard treatment of patients suffering from this chronic lung disease. And it addresses the issues of treatment holistically. It will provide education, nutritional intervention, exercise training program, patient assessment, and psychosocial support. It is very important for the family to be involved in the treatment of these patients because there are many psychological issues that has to be addressed in terms of treatment. One of the goals of a rehab program is education on self-management. You want to give these patients knowledge and skills that would let them to be to self-efficacy, eventually lead to some behavior change that would produce positive health effects. So it's really educating these patients on the type of illness and how to go about the treatment of this illness. One of the things that is done in a pulmonary program is an exercise testing. We want or we are looking for certain parameters as to determine the baseline characteristic of these patients. Aside from pulmonary function testing, we also do exercise testing to determine the extent of their exercise capacity. Now, a core component of a rehab program is actually education. It can vary from the traditional didactic lectures to self-management. And right now, because of the COVID-19 pandemic, pulmonary rehabilitation programs are also having what they call tele rehab. Now, topics would include laymanized lectures and discussions on anatomy, pathology, physiology, breathing techniques, medications. So it's basically similar to a clinic where a doctor will be explaining to these patients what their medicines are, why they are being given. It is important for these patients and their uh, caregivers to understand the disease because it is through understanding that there is an enhancement of compliance in terms of doctor's recommendation. So educational sessions can be in a classroom atmosphere such as this. Same with group sessions, but in the advent of the pandemic, telerehab group sessions will be given as part of the service. The other cornerstone of rehabilitation will be exercise. We exercise both the upper and the lower extremities. We have seen patients who cannot even do basic functions like dressing themselves, combing their hair, washing their face. So these are all taught in a rehabilitation program to be able to improve their ability to do their daily activities. And this is a typical picture of rehab. So you have the health professional examining the patient, and you have the patients in the background doing their exercise under medical supervision. And we have shown that rehab programs such as this works. It can improve their ability to exercise. This is the result of our 6-minute walk test that showed the improvement in the number of meters that the patient can walk after the program. We have also shown that we are able to improve their symptoms after the rehabilitation program. And we have a significant impact in terms of hospital confinements, reduction of hospital confinements, and emergency room visit for those who are able to finish the program. Although I said that we will be discussing a topic different from COVID, we will still have to go back to COVID. And the question that I would like to answer is, has it affected patients with COPD? Now, this is a study. It's actually a review and meta-analysis. It reviewed several papers, and this is the data that was shown in that study. Okay, the crude fatality or crude case fatality rate of COVID-19 in general is 7.4%. Their pooled prevalence rates actually showed that for COPD patients, prevalence rate is only 2%. For those who are smokers, it's 9%. However, even these numbers are small. You can see that once this patient is afflicted with COVID, there is a much higher risk of a severe disease. So that's 63%. Compared for those, and this was associated with a higher mortality rate of around 6%. So even if this data shows that there are less COPD patients affected, I think this is due to the fact that these patients are being hidden somewhere in terms of when they are affected, the problems of morbidity, mortality, and complications are much higher. And this is easily understandable because they are immunocompromised. And all the inflammatory things that are occurring in COVID is exaggerated in these immunocompromised patients, therefore leading to a more complicated disease. And okay, for those smokers, so yung mga nagsisigarilyo, medyo makinig ng mabuti. Okay, there is showed that for those smokers, there is a 1.45 times of likelihood that you will have severe complications of COVID-19 when compared to non-smokers. And this is the reason why the WHO has already given this advisory. Smokers are more prone to COVID-19. This is the warning coming from the World Health Organization. Now, GOLD has been trying to help in terms of guidance of physicians in going about patients with COPD that may have the potential of having the COVID disease. And what the GOLD encourages is for people with COPD to follow the advice of public health teams so that you try to minimize the chance of being infected with the disease. And if you have the symptoms, to seek medical attention as soon as possible. So chances of you, if you are not exposed to COVID patients, chances of you getting the disease is less as far as this data is concerned. But when you get it, you will be greatly affected by the disease, and this can lead to severe disease and even mortality if not given the proper medical attention. So more so exacerbation. When you say exacerbation, this means worsening of the disease. And if a patient is exposed to COVID-19, affected by COVID-19, the likelihood of exacerbation is very high, and the likelihood of complications likewise will be very high. Right now, in terms of the use of corticosteroids, there has been no advisories on not to give corticosteroids in these patients for as long it is medically supervised and the treatment is warranted. This medicine can be given. The patient should be maintained on their regular therapy, and they should be provided with oxygen therapy if warranted, especially for those patients with significant hypoxemia. Okay, let me tell you again that among the smokers, there is a much higher chance of you getting the more serious COVID-19. So if you smoking even until this time, the best thing you can do is stop smoking. We earlier said that the normal function of the respiratory system is breathing. If you have a normal lung and you get COVID-19, there will be problems. If you have a normal lung, like chronic obstructive lung disease, the anticipated problems is really much higher. So the real message really is for all of us, whether you have COPD or no COPD, is to take care of ourselves, follow the advisories that are being given by the WHO and our DOH so that we can avoid the disease altogether. I hope you were able to grasp the main message of our lecture today. There is an old saying, it is an ounce of prevention is better than a pound of cure. So if you can avoid having COPD in the first place by doing the things that were recommended earlier, that's better. But if you have chronic obstructive lung disease, it is best that you consult your doctor because you may have to undergo spirometry and other ancillary procedures so that the disease can be addressed. Again, there is no cure for COPD, but there are a lot of treatment available to make the lives of these patients more comfortable. Thank you very much for your attention. I think we will be ready for our Q&A after this lecture. Thank you.